This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken with prior written consent of the AARC. Copyright 2011. All rights reserved. My name is Bill Dubs. Sorry about that. My name is Bill Dubs. I am the AARC Director of Education and Management Services, and I welcome you to today's presentation on setting the ventilator for maximum patient comfort. This program is sponsored in part by an unrestricted educational grant from CareFusion. Reagan Hickey will take a few minutes to familiarize you with our sponsor. Reagan?
Thank you, Bill. Protecting a patient's lungs is crucial throughout the care process, but it's most important in the critical care environment. For more than 50 years, CareFusion Respiratory has been advancing, connecting, and empowering clinicians with innovative technologies and services to measurably improve patient care. CareFusion has a long history of innovation and advancing the practice of respiratory care. With more than 50 years of first-to-market technologies from CareFusion's brands Bear, Bird, SensorMedics, Pulmonetics Systems, and Viasys Healthcare, CareFusion has a breadth and specialty in ventilation that is unprecedented in the industry. For more information, please visit CareFusion at www.carefusion.com. Back to you, Bill.
Thank you, Reagan. At the completion of today's webcast, participants will be able to explain how dyspnea differs from breathlessness, recall the three main clinical components of dyspnea and give examples of each, explain how ventilator settings of flow rate and tidal volume affect patient work of breathing, describe the mechanism by which pressure control ventilation may decrease patient work of breathing, and describe how pressure support level, pressure rise time, and flow termination criteria can adversely affect patient work of breathing in obstructive lung disease. I am pleased to introduce Rich Kallet. Rich is a registered respiratory therapist and an AARC fellow. Rich is also a fellow in the Society of Critical Care Medicine. Currently, he is the Quality Control Manager of the Department of Respiratory Care at San Francisco General Hospital of the University of California at San Francisco. Rich has been in the field of respiratory care for over 35 years and has been involved with clinical research for 25 years. One of his primary areas of research interest has been respiratory muscle function and patient-ventilator interactions, on which he has published and lectured extensively. Mr. Kallet discloses that he consults for Puritan Bennett Covidien and Viasys CareFusion on issues related to mechanical ventilation. Rich, welcome to the program.
Thanks. I'm glad to be here, and I've got a lot of material I'd like to cover, so let's just jump into this. Hope everyone can hear me okay. I didn't put that as a question to vote on, but all right. So when we talk about setting the ventilator for patient comfort, we essentially have to talk about dyspnea or discomfort. And I just want to spend a few minutes at the front of this talk going into it, because we don't really get a lot of training on this as respiratory therapists. So dyspnea is the perception of difficult or labored breathing. It's actually a very complex phenomenon that possesses diverse qualities because it has multiple inputs. These being mechanical, chemical, subjective. There's a dynamic aspect to it that the sense of dyspnea changes over time. It's also conditional or contextual, and for that I mean that the perfect example is when you exercise maximally and your breathing is up because you have hyperpnea. That is a very normal experience, and we know when we stop exercising, our breathing comes down. If you were to basically sit in bed and have that same type of breathing pattern, it would be extremely distressing. because it would be out of context and because we would automatically perceive that there's nothing we could do to get rid of the sensation. So that's a very important aspect when we talk about dyspnea. And it's also something that is blended by past experience. I kind of started there for a second. This is not true confessions, but when I was 3 years old, I almost drowned. So anything that inhibits my breathing automatically triggers probably a more intense experience than it would for many other people. But it's something to keep in mind that all our patients have experiences with dyspnea and labored breathing that may impact or color how they respond to our therapy. Now, there's a major distinction between dyspnea and breathlessness. And dyspnea relates to an excessive work of breathing. It's related to disturbances in chest mechanics, resistance, or compliance. It also is affected by muscle weakness. And patients, let's say with COPD, whose lungs are over-distended, the muscles get stretched out, so it requires much more force to get a pressure change. That relates to dyspnea. And loaded breathing, altered resistance and compliance, relates to the sense of dyspnea. Now, there is another distinction, the term breathlessness, and that it actually has a physiochemical etiology. It's related to an abnormal drive to breathe. And of course, the major inputs to that are carbon dioxide and pH. Now, normal sensations of breathlessness we can get with breath holding or at maximal exercise, and we're not sure how that relates to pathological sensations of breathlessness, but it's probably fairly close. There is also a psychogenic component to breathlessness, what's known as hyperventilation syndrome, and this is probably an abnormal sensation or mechanism within the brain that what would normally be sensed as a satisfying breath in these patients doesn't. It's not something we really understand all that well. Now, the clinical components of dyspnea that we're going to be concerned about in this talk break down into three main areas. And let me get a pointer up here for a second. So we have muscle strength, and there's a number of things that go into that. Intrinsic muscle load, so the resistance and compliance of the patient, their FAARC, the tidal volume. Again, things that we can't really control all that well. And then the things that we can control, which are the ventilator settings. So the tidal volume we choose, the flow rate, the flow contour, the trigger level, the inspiratory time, the PEEP, and the expiratory resistance. And those are the things we really need to keep in mind when we're setting the ventilator to try to keep the patient comfortable. Now, the root cause of dyspnea goes by three different terms. It's called length tension inappropriateness, or neuromechanical dissociation, or efferent-reafferent dissociation. Those are kind of loaded words. And essentially what it comes down to is that when you take a breath, when the motor cortex sends a signal to the diaphragm and the other muscles to contract, there's a copy signal or a copy discharge to the afferent cortex, the part of the brain that receives signals back on how much and how fast the chest wall and the lung tissue are displaced. So there's kind of a matching. So our sense of normal breathing, what's normal and effortless to us, is a matching between the effort we put into a breath and how quickly and how much displacement we get in the chest itself. Now, dyspnea can be thought in two ways. First is that it's tension developed in the respiratory muscles that's disproportionately greater than the corresponding chest displacement. And this is related to excessive loads, such as decreased compliance or increased resistance of the chest. There's also a slight variation of that, which is efferent discharge to the respiratory muscles is greater than the corresponding chest displacement. So the subtle difference is that patients with muscle weakness, patients that have poor nutrition, that have respiratory muscle fatigue, or patients with spinal cord injury that can't recruit most of their muscles, that the problem is that they get almost a sense, what I call brain throbbing, that you become aware of actually the motor command to the muscles and that is out of proportion or excessive relative to the displacement you sense in your chest. So it's believed that this imbalance stimulates the reticular activating system in the brain and brings that sensation into conscious awareness. We are normally not aware of our breathing at any one time, but it's only when the work becomes excessive or the drive becomes excessive that we begin to focus on this. Now, how do we translate this into ventilator settings? There are three clinical loads that we need to be concerned with, and they are the elastic load, which is related to volume, tidal volume, or the tidal volume demand of the patient. Resistive loads, which is related to the flow rate, either the flow rate generated by the patient or the flow rate we set on the ventilator. And what we know is threshold loading, which is when the onset of muscular contraction doesn't equal the onset of volume change. And we're all familiar with this, that when we have the trigger level set on the ventilator that's too insensitive, or there's intrinsic PEEP built up in the circuit in the patient, that the muscles contract, but the ventilator triggers much later on. So the muscles contract, but there's no change in chest volume. So that's also a very uncomfortable sense of breathing. Now, there's certain clinical rules of thumb that we have with setting the ventilator for patient comfort. The first is that the flow rate and the flow pattern approximates the velocity of muscular contraction or the speed at which the respiratory muscles develop pressure. And the tidal volume approximates global inspiratory muscle shortening. So matching or exceeding these things on the ventilator versus what the patient wants has a lot to do with whether the patient is comfortable. And for this, I like to use the idea that the ventilator acts like a spotter for a weightlifter. So when the tidal volume on the ventilator is greater than or equal to the tidal volume demand by the patient, and the flow rate on the ventilator is greater than the flow demand of the patient, and in this we're assuming that we have minimal trigger sensitivity, the ventilator should displace the chest faster than the patient, and therefore when the respiratory muscles contract, the load on them is much less. And any of you who have or are gym rats out there and like to do bench pressing, you will automatically relate to that. But that's basically, the ventilator is a spotter for the patient. Now, how does this work technically? This is a slide which I'll kind of go through in a little detail here. And this is from a study that we published in Respiratory Care back in 2002, and is a lung model set up looking at imposed work of breathing with tidal volume demand. And what you see on this top frame here is a patient tidal volume demand that was simulated. The ventilator tidal volume was 400. So we see that the tidal volume demand in the model was going from 50, 75, 100 to 125% of what was set on the ventilator. And the blue line was CPAP, was just the intrinsic load on the lung model, or the simulated patient load, to get that size breath and the flow rate generated with it. And you can see that the work of breathing goes up slightly as we pulled in the breath, as the patient pulled in the breath. Now the red line is volume control with a constant flow, and the gold triangles is volume control with a decelerating flow. And you can see that around 75% of tidal volume demand, where the patient is trying to pull in 75% of what's set on the ventilator, the work of breathing really starts to rise with constant flow and rises almost 5 times normal. And by using a decelerating flow, where we increase the flow rate at the very beginning of the breath when effort is maximal, that we can kind of offload that. But once we get above 100%, the imposed work starts going way, way up. So the fact of the matter is that when the tidal volume demand of the patient exceeds what we have set on the ventilator, remember, in volume control, it's trying to maintain a constant tidal volume from breath by breath. So if it sees that the patient is trying to pull gas out of the ventilator beyond what it's supposed to be delivering, it will actually increase the resistance and increase the workload. And then down at the bottom, it just shows that the ventilator work of breathing actually falls to about 0. So this becomes a very important issue in terms of patient comfort. Now, I kind of alluded to this, and here we see the pressure tracing in volume-controlled ventilation. If it was a passive breath, you would have the classic pressure step and slope up, but during patient-triggered ventilation, if there's flow starvation and mismatching, you'll see kind of a scooped-out appearance. So this is classical. And what's not appreciated, and it's kind of subtle in this picture here, is that as the patient tries to suck gas out of the ventilator faster than it's programmed to deliver, the ventilator flow rate will actually go down below preset to try to limit the tidal volume. So this puts a huge load, or can put a huge load on the patient's muscles. Now, let's talk about threshold loading for a second. And this is from a study we published in Respiratory Care back in 2000. And it's a Campbell diagram, which is how we measure work of breathing. I just want to orient you to this very quickly, but the area in this loop is patient work of breathing. And I want to focus, and this is negative esophageal pressure. So here's the baseline pressure. We see a line here. This is chest wall compliance. But this red line here is the baseline pressure. And as you breathe in, pressure becomes negative. Negative pleural pressure, esophageal pressure, muscle pressure. The second line here is what the, excuse me for a second, is the onset of actually inspiratory flow rate, and then we get volume change here. So this is kind of a trigger delay in a response from the ventilator to where it actually starts delivering flow. And you can see this large change in pressure is actually a threshold load. The patient's contracting their muscles, but they're not actually getting a sense of chest displacement. So this is hugely uncomfortable. There are some things we can do to alleviate that with setting the ventilator, but some of this we probably can't do anything about because it relates to actually how stiff the lungs are. Now, the causes of threshold loading, things that we can actually deal with, our insensitive trigger level. I think most of us are very aware of that. We try to keep the trigger as sensitive as possible. Intrinsic PEEP is something we try to limit, and we sometimes will set the ventilator PEEP level to match that or come close to it to decrease the threshold loading. Now, some of the things that also cause threshold loading are asynchrony, where effort occurs at end inspiration or early expiration, a patient who's extremely tachypnic. So they're trying to pull in a breath when their lung volumes are very high and they can't trigger an additional breath. And there's not a lot outside of sedation we can do with that. There's also the possibility that decreased lung compliance or increased airways resistance itself may cause threshold loading because of an ineffective transmission of muscle pressure to the circuit. So in cases where patients have increased respiratory drive, the rate of muscle pressure development over time, over a fixed trigger phase, causes that increased pressure amplitude, which I was showing in the previous slide. So threshold loading is something that's underappreciated. There are some things we can do for that and some things that we probably just have to treat with sedation, again, in a patient who's extremely dysynchronous. Excuse me again. Now, tidal volume mismatching, which we talked about, is another area which has become much more significant in the area of lung protective ventilation. And this is from a study we published in Critical Care Medicine back in 2006, and we had patients on ARDSNet settings, and we just lowered their tidal volume in steps from 8 to 7 to 6 to 5. And you'll notice that the work of breathing progressively increases. And at some point in this particular patient, the tidal volume that we set on the ventilator was greater than what they wanted, and we had this huge rise in work of breathing. So this is why we used higher levels of sedation in patients with very, very severe ARDS, where we have to protect the lungs. And we can see that when tidal volume is set below what a patient wants to protect them, that can cause extreme increases in work of breathing. And you'll also notice that the threshold load, again, this area between the two bars, becomes wider as the tidal volume goes down. This may be a reflection of just the increased respiratory drive, which magnifies the threshold load. But again, it can cause a tremendous amount of patient discomfort. Now, detecting tidal volume mismatching, one of the classics that you'll see on graphics tracings is the sawtooth configuration. And this is one where the patient is out of sync with the ventilator. They may trigger a breath, and then when the breath stops delivering the flow, they continue to suck in to try to get more air. And in some cases, the patient triggers after the ventilator triggers. But kind of a sawtooth in the airway pressure change is a kind of a good way to detect tidal volume mismatching. Now, clinical tricks of the trade for volume control. Some of these are just standard, I think, things to think about that you can start out with. And one of them is just the initial peak flow rate should be about 60 liters a minute. That's about double normal for you and me at rest. 50 to 75 is kind of a good range. Beyond 75 liters a minute in most patients, I don't think you get that much bang for your buck, but you can always try it. Now, for patients who don't have ARDS, I think the default for lung protection should just be 8 mils per kilogram, just to be safe. And we can always titrate that up in steps of 1 mil per kilogram, which is usually 50 to 80 mils, to try to get patients more comfortable. And again, trigger sensitivity that's most sensitive without increasing the risk of auto-triggering. In COPD patients, using PEEP titrated in 1 centimeter steps to counteract the threshold loading from intrinsic PEEP is good. And then there's another trick of the trade, which we've instituted at San Francisco General this past year, but something we've been using unofficially for decades, which is a quick CPAP evaluation. I'm going to talk about that in just 1 second. Now, in a quick CPAP evaluation, you have a patient at the bedside who is very dysynchronous. What you want to do is use the same PEEP level that they have, use a safe FiO2, and just quickly flip them over to the CPAP mode for only about 20 to 30 seconds, depending on their stability, and look at the graphics to see what is the patient trying to pull. This is probably the quickest way, rather than fiddling with 5 or 6 different modes, to assess what is actually going on. So, with this, what is the tidal volume that the patient's trying to pull? What is their peak flow rate? Also, what is their flow profile? And what is the inspiratory time? And how does that relate to what we're trying to deliver with our settings? And also, how much variability? If someone is pulling a tidal volume or a flow rate greater than what's set on the ventilator once every 6 or 7 breaths, in that range, I wouldn't worry too much about changing your vent settings. But obviously, if every breath is outstripping what we have on the ventilator, we have to make some decisions. And the decisions come down to 2 aspects. Number 1, what are the relative risks of ventilator-induced lung injury in this patient versus what is the need to limit sedation? This should guide the physicians and the respiratory therapists to kind of huddle together to figure out a care plan. So in patients with ARDS, or patients who are very much at risk for ventilator-induced lung injury, particularly early in the course of their lung disease, probably lung protection is much more important, and sedation should probably be increased. On the other hand, patients who are recovering from their disease, who are trying to wean and drop their sedation level and get them extubated, they're probably at less risk of ventilator-induced lung injury. And liberalizing our ventilator settings or putting them in a spontaneous mode entirely may be the appropriate choice. So let's talk a little bit about pressure-regulated ventilation. Most people reflexively think that pressure control or pressure support improves work of breathing. Very often it does, but as I'll show you, there are some aspects of that which don't always play out. Now, going back to the lung model setting, this is kind of a quick way to show how pressure modes improve patient work of breathing. And again, this is the spontaneous flow rate from the lung model as the patient was trying to suck in 200 to 500 tidal volumes. And at baseline, under pressure control, passive ventilation, the peak flow rate was 60. And as the patient starts to pull in breaths with increasing tidal volume demand, pressure control mimics that and increases the flow output. And the effect on tidal volume is also similar. This is from the lung model. In that passive ventilation and at 200, only 25% tidal volume demand, pressure control maintains around the same tidal volumes as volume control. But as the tidal volume demand of the patient approaches what we had set on volume control, at around 75%, at least in this lung model, that the ventilator starts delivering more tidal volume. So essentially, pressure control is a spontaneous breathing amplifier, and the same with pressure support. The harder you pull, the more flow in volume it will give you, and that amount of flow in volume will be dependent upon the patient effort and also dependent on the pressure level you have chosen. So putting this together, putting the pressure control in with the volume control, what you'll see again, the blue is the unassisted breathing or the intrinsic load, workload on the muscles, that as the tidal volume demand goes up, the work of breathing imposed on the patient goes up in volume control decelerating and volume control constant flow. But pressure control maintains work of breathing actually below the patient's intrinsic load. It actually offloads the work of breathing. So this is something good. That's a good tool to have in the tool chest. Unfortunately, there's a downside to pressure control. And a lot of this relates to ventilator-induced lung injury and attempts to do lung protective ventilation with pressure control, is that we have poorly controlled tidal volume in pressure control. So the more tidal volume they want, they can get it. It's compassionate, but unfortunately it increases the mortality risk from lung injury. And because the ventilator work of breathing is fixed, remember, if we're setting a fixed peak airway pressure, we're fixing the total amount of work of breathing the ventilator can do. So as chest mechanics deteriorate, that workload is shifted onto the patient. And it's one of the reasons why volume assist control is kind of the first mode of ventilation that clinicians choose, because as chest mechanics change, the ventilator will increase its work output to maintain your tidal volume. Now, the other aspect of pressure control, kind of the downside, is that as you decrease the pressure control to limit tidal volume delivery for lung protective ventilation, you also decrease the peak flow delivery and you decrease the ventilator work of breathing. So paradoxically, this can actually increase the patient work of breathing, particularly when they become asynchronous. Now, this is from a study we published in Respiratory Care back in December, I think, of 2005, comparing volume and pressure modes during ARDSNet. And what I want to draw your attention to in this is here's kind of the standard flow wave pattern we'd typically see in pressure control, kind of a decelerating flow. It's hunched out a bit because the patient was sucking in. But notice in these first 3 breaths, that we have an abnormal pressure control flow pattern. And on the pressure, we have these huge pressure spikes at the beginning of the breath. What was happening in this particular patient? They were asynchronous. The ventilator was triggering, and then the patient would trigger. And this happens quite frequently. So the patient's bearing down, the ventilator kicks in, it automatically truncates the flow pattern, and then as the patient kicks in, instead of a decelerating flow pattern, we get an accelerating flow pattern, which also can increase the work of breathing. And in the study, we found, very surprisingly, that the work of breathing actually was somewhat higher in pressure control than volume control using ARDSNet. It wasn't statistically different, it wasn't really huge, but it was a surprising finding. So automatically switching someone to a pressure mode, particularly during lung protective ventilation, doesn't necessarily mean their work or breathing is going to be better. Now, the sister mode to this is pressure support. So it's basically all the flow and pressure principles of pressure control, but with a completely spontaneous breathing, no fixed I time, no fixed rate. Now, the advantage of pressure support is that it gives the patient control over their peak flow rate, their tidal volume, and their inspiratory time. And I think this is best used when the patient has an intact respiratory drive, they have good muscle strength, and only moderately abnormal resistance and compliance. And full support, just as a rule of thumb, okay, this is just a starting point, is about a delta of 15 centimeters of water. And if you look at all the studies of spontaneous work of breathing and different lung diseases, that patients will usually pull somewhere in the neighborhood of 15 centimeters. So starting with 15 is probably a good way to kind of mimic what the patient's trying to do and hopefully offload their work of breathing. And we titrate that, of course, by respiratory rate and tidal volume and accessory muscle use. Parenthetically, I would avoid personally pressure support levels much greater than 20 to 25. To me, that indicates that a patient is probably too sick for pressure support. And the thing to remember is that in pressure support, because it's a spontaneous mode, the patient cannot use the ventilator like water wings or a kickboard, what a kid would use to, when they're first learning how to swim, they get tired, they can kind of coast on the ventilator. That the patient is forced to work much harder or continuously, because if they're not pulling in, they don't get any support from the ventilator. Now, pressure rise time is a real nice feature on pressure support and pressure control ventilation, but it has a downside. And I think the upside to it is when you have patients with what I like to call twitchy airways, that you give them a robust breath with a high flow rate, particularly if they have asthma or COPD or Kaposi sarcoma of the airway, you can cause reflexive coughing. So adding a little bit of pressure slope to the breath, okay, can help alleviate that. But as you go up on a higher pressure slope, what you're doing is you're decreasing the peak flow rate, and you're pushing the peak flow rate to a later point in inspiration. And remember that your peak inspiratory effort occurs much earlier in the breath, normally around 25% of inspiration, but that can go down to probably about 15% or maybe 10% in extremely high level workload. So that's something to really keep in mind. We can go overboard with the pressure rise time. Now, expiratory percent flow termination and pressure support, it's been given the unfortunate name of expiratory trigger level. It's actually an expiratory cycle level. And normally that's been about like 25% of the peak inspiratory flow rate on most ventilators. But we can now set that to different levels. Now, this is something to be aware of in patients with severe COPD. And this is from a study by Tissot, that they used a pressure support of 14, a modest amount of slope, 0.2 seconds, and they changed the expiratory flow cycle up to as high as 70% of the peak inspiratory flow rate. And the higher they went up, they decreased the intrinsic PEEP level, they decreased the ventilator inspiratory time, they decreased the tidal volume that was delivered. That may seem kind of paradoxical, but actually in COPD, you want to limit the tidal volume delivery to prevent more air trapping. And what this did was it decreased the amount of ineffective triggers and trigger delays that these patients suffered from, and it decreased the work of the diaphragm by about 30%. And that was just going between the standard of 25 to 50%. Now, I think, again, like the pressure rise time, you can get a little bit too carried away with this. But I think with patients with COPD, going to like a 40 or 50% expiratory flow termination criteria may help. Remember, high levels of pressure support in patients with COPD doesn't help them that much. It can actually make their work of breathing much worse. And this is just a slide to show how dynamic hyperinflation causes asynchrony. The peak EMG of the diaphragm, which is peak effort, you can see with a excessive pressure support level that the patient becomes dysynchronous. Okay, and that where the patient, the peak EMG, I'm sorry, I kind of misspoke here. This spike here is right at the point when the diaphragm is about to turn off, and you can see that because of the flow termination criteria is much greater than what the patient can interact with, we have an excessive inspiratory time that causes more air trapping. I'm actually going to skip through some of these slides and kind of go to a summary here. So complete spontaneous mode, it forces the patients to work continuously. They can't ride the vent. We should avoid high levels of pressure support or high levels of slope time, particularly in patients with COPD. And using a higher flow termination criteria in these patients is probably better, but something you have to figure out at the bedside. And monitor these patients very, very carefully for intrinsic PEEP and uncaptured breaths. And P01 is something that's available on some ventilators. It's kind of a reflection of respiratory drive. It's really only valid in patients who don't have muscle weakness. And basically when that level's above 7, they're probably in a fatigue range. And kind of limit the slope time. We're using the slope time a lot for patients that have coughing, but it is an effective mechanism for that. Now, pressure-regulated volume control, also known as adaptive pressure ventilation, autoflow volume control plus. All this is pressure-controlled ventilation with a tidal volume target. And how it functions is that it increases or decreases the pressure control level in 1 to 3 centimeter steps per breath based on tidal volume deviation from what you have programmed into the ventilator. And when the patients trigger and interact with the ventilator, PRVC initially alters the peak flow pattern according to patient effort, just as pressure control would. And one of the advantages of this mode, some ventilators have it, some don't, is the active expiratory valve, which is actually a wonderful feature for asynchrony. But the problem with this is the floating pressure control level is used as a way to keep tidal volume at a target, and it always assumes that when tidal volume exceeds the target, the lung compliance must be improving, therefore it decreases the pressure control level. Now, when patients start pulling a larger tidal volume than what's programmed in, the ventilator is going to start decreasing the pressure control level, which decreases the flow output and actually shifts the work of breathing onto the patient. So you need to be very careful with this mode. As long as tidal volume demand of the patient is less than or equal to the tidal volume set, the flow and tidal volume variation should promote patient comfort. But once that tidal volume demand, if it is pretty much greater than the tidal volume set on the ventilator, all this is going to do is increase the work of breathing and progressively shift it to the patient. So the rule of thumb I have with this is that the minimum peak inspiratory pressure during lung protective ventilation should be about 20 to 25 centimeters of water, depending on your PEEP level. So in other words, you want it about at least 10, probably more like 15 centimeters of water greater than your PEEP level to ensure that the ventilator is actually offloading the work of breathing. Okay. Now, most versions have a minimum pressure control, which is about 5 centimeters of water above your PEEP level. And we've restricted this mode at San Francisco General. Basically, we found a number of patients whose pressure control, whose peak inspiratory pressure on autoflow was 5 centimeters above the PEEP. So they're like 10 over 5. And many of these patients were in overt shock, a couple of them in cardiogenic shock, and they're basically getting no support from the ventilator. And the fact that there's an active expiratory valve, they couldn't pop off, there was no signal to the clinician warning them of this. So you need to be very, very careful with it. And also, poorly controlled tidal volume likely increases the mortality risk in ALI ARDS. Now, talk a little bit about proportional assist ventilation and neurally adjusted ventilatory assistance. This is actually a very intriguing mode of mechanical ventilation, and it adjusts the pressure assist level from the ventilator to share work of breathing and to maximize synchrony. So rather than, or in distinction to pressure support, pressure control, which has a fixed airway pressure that augments flow and volume delivery with increased effort, this directly responds to increased effort with a proportionally greater pressure output. And this is actually a nice idea. There's no set pressure, flow, volume, or time. And it's intended, again, as a partial ventilatory support. It's not intended for patients with very, very severe lung disease in the acute phase. They'd actually need a fixed rate and a fixed I time in either a volume or pressure mode. So it's appropriate for use in patients with intact respiratory drive, reasonable muscle strength, who are not critically unstable. So the way to think of this, it's Warren Sanborn has called it power steering for breathing. And conceptually, here's pressure from the ventilator, and here's increasing patient effort. So in pressure control, increasing patient effort, the pressure control level stays fixed. And as we saw before, in volume control, increasing patient effort, the pressure from the ventilator goes down, the work of the ventilator goes down, and in PAV and NAVA, increasing patient effort is met with increasing output from the ventilator. Now there are pros and cons to this. In the pro side, it improves synchrony. It may decrease work of breathing depending on the level of support, keeping in mind that you can set the level of support from like 25 to 100. I think you can go way above that and greatly offload the work of breathing. It may prevent overventilation and gas trapping. And in patients in non-invasive ventilation, it may cause better sleep quality. And NAVA in particular, because it's based on esophageal triggering from the esophageal electrode, which picks up diaphragmatic contraction, it may solve the threshold loading problem. On the con side, it's not really appropriate, or may not be appropriate, for patients with muscle weakness and fatigue in the face of increasing muscle loads, because essentially less effort is less support. So if someone becomes weaker, the patient limits the amount of work they're doing, the ventilator doesn't give more support. In NAVA, increased respiratory drive in the face of increased airways resistance can cause hyperinflation. Keeping in mind that what's triggering the ventilator and the ventilator output is the muscle contraction or the neural input to the muscles, and as that becomes heightened, the ventilator output becomes heightened. It's also semi-invasive. You have to stick an esophageal electrode down. So I think it has limited application. PAV requires calculation of resistance and compliance. There is an automated calculation. However, we're not really sure if that would be accurate enough. So we've got about 5 minutes to wrap this up. I'm going to try to highlight a few extra comments here that relates to it, which is what are the limits of unloading respiratory muscle during IMV? So when spontaneous ventilation reaches a specific level of total ventilation, the patient no longer responds to assisted ventilation by reducing effort. And that was something that was brilliantly shown by John Marini in a paper back in the 1980s. And what this means is that when you have the SIMV rate set close to the patient's total spontaneous rate, it works well in reducing work of breathing. But when you start getting down to IMV levels of 6 or 4, again, depending on the patient's spontaneous rate, that the mechanical breaths likely do very little to offload the work of breathing. And this is because the target output in terms of the patient's inspiratory effort is likely influenced by the previous breaths. Also, that in patients with severe respiratory muscle or severe respiratory failure and muscle weakness or at the brink of muscle fatigue, that the patient's output may be fixed and refractory to the effects of flow rate and volume. So it's likely that there is a pre-programmed force target, and it's probably a survival mechanism built in through evolution in the extreme cases to try to prevent us from shredding our muscles and dying. Now, this is again from Marini's paper, just to show that during the work of breathing, here we see during controlled, where the IMV is at 100% of effort, and as the spontaneous efforts go up, let me change this. That the work of breathing, actually during the mechanical breaths, follows the spontaneous mode. Okay. Talk a little bit, very, very briefly, about airway pressure release ventilation, because it kind of follows along with IMV. And basically, airway pressure release ventilation, it's 2 levels of CPAP, a high and a low CPAP, and the changes between these two can cause a tidal volume change, and the patient can actually superimpose their spontaneous breathing effort on top of that, and that supposedly deals with the issue of asynchrony. If the patient can superimpose their breathing pattern at will, then we've kind of solved the asynchrony issue. That really isn't true, but that's the idea behind this. And there are 4 actually distinct breathing environments with perpetual load changes during APRV. If you want more details on this, we published, this is from a publication that we did this spring from the Asynchrony Conference. It's in Respiratory Care, I think from February, but as part of the journal conference on asynchrony, and this was again from the study that we had published years ago on lung protective ventilation, but we had some extra data that we had collected on APRV. And essentially, the advantages of APRV, the active expiratory valve removes bucking. That is a huge advantage. We can get that on other modes, though. But the theoretical benefits of the mode in terms of patient work of breathing have not been reproduced clinically, and in our small series of patients, it was actually much higher than traditional modes of ventilation. So in ending this up, one of the things I want to emphasize, again, is the concept of a fixed neuromuscular output from the respiratory centers in patients who have respiratory muscle fatigue, or what we call incipient fatigue, where to save the organism, the brain shuts down the amount of work output. The advantage of this is that it suggests that standard assist mechanical ventilation modes may be sufficient to control patient work of breathing, and actually may promote more comfort in severe disease, because the patients aren't breathing all over the place. They have a fixed output. And that sophisticated closed-loop modes may be better applied to patients without respiratory muscle impairment, in whom the work of breathing pattern is highly variable. And I'm sorry if you can hear that ambulance going by my front door. And lastly, we can't always optimize patient comfort on mechanical ventilation. There are limits to what we can do to relieve dyspnea, and sometimes we just have to rely on sedation, and particularly in patients that are very, very critically ill. It's always a balancing act. And with that, I think I'm going to hand this back over to Bill, and I want to thank you very much, and I'll be back in a few minutes to answer some questions.
Thank you very much, Rich. A very, very excellent presentation. And this is your time, folks, to get your questions entered into the onto the screen there, so that we can respond to them. We have about 7 or 8 minutes remaining in the webcast. Rich, I'm going to go back to a couple of the questions that came in. We only had a few questions come in during your presentation, but we may have a few more coming in now. But let me go back to some of those. The first question that came in was, how do we assess peak flow and inspiratory time when in a CPAP mode?
Very good question. I'm sorry I kind of glossed over that. Just use the graphics on the ventilator. I think most of the ventilators we have out now, you do have a graphics package on the screen, And you can either just do it in real time, just kind of look at the peak flow rates, because they're formatted so you can actually kind of estimate the peak flow rate, or you can do a screen freeze and move the cursor. So one of the things we do is we'll just run like a full screen. We'll freeze it, and we'll put the patient back on assist control, then go back and scroll through and see what they're trying to do. So if you don't have a graphics package or a digital readout of peak flow rate, that's not going to be that helpful to you. But at least you can get an idea of what the tidal volume demand is. But thanks for asking that question. That was hugely important. I kind of glossed over it.
Okay. Another question that came up was, one person was asking if you could make some comments about PRVC.
Okay. I'm not sure at what time that came in.
Yeah.
I did kind of cover that. If that person could actually... If there's something I didn't do with that, I'm glad to answer it. But
okay, we'll give that person a chance to send another message to us then. In the meantime, there was a comment that came up. Could you please emphasize about auto PEEP due to inappropriate ventilator settings? How can it be minimized to impact on the cardiovascular system?
I'm sorry, could you repeat that again?
Yes, how can you please emphasize, talk about auto PEEP due to inappropriate ventilator settings, and how can it be minimized to impact on the cardiovascular system?
Okay, so in terms of ventilator settings, auto PEEP is essentially a tidal volume that is too large for the expiratory time that the patient has. So in other words, when you have obstructive lung disease, it takes a lot longer to equilibrate, or to exhale your tidal volume. So you're dealing with the resistance of the circuit, the amount of PEEP you have on, the size of the endotracheal tube, if there's bronchoconstriction or mucus. If you have an inspiratory time that's too long, particularly at a high respiratory rate, it's going to prevent the lung from emptying. So setting I times, we typically use inspiratory times in controlled ventilation, or in assist controlled ventilation, of about 0.7 to 0.8 seconds in patients with obstructive lung disease to get an IE ratio of about 1 to 5 or greater. In a spontaneous mode, this is really, really important. One of the major problems is with high levels of pressure support, depending on your flow termination criteria. High levels of pressure support increase the inspiratory time. A large pressure rise time, or a long pressure rise time, increases inspiratory time, and a slow flow termination criteria. So all three of those things can cause air trapping. And paradoxically, we don't really want to give patients with COPD large tidal volumes, the same as we don't want to give them with ARDS, but for different reasons. Okay, so using pressure support levels of probably in the range of 10 in patients with COPD with a high flow termination criteria of about 40% maybe, and a minimal rise time should help limit inspiratory time and tidal volume and prevent more gas trapping. And that less gas trapping should help maintain blood pressure. So it's the first thing, if someone is hypotensive with COPD or status asthmaticus, the first thing I'd be worried about is air trapping, measuring intrinsic PEEP, and trying to minimize that.
Okay, Rich, if I could direct your attention over to the chat box now and look at some of the later questions that have come in. We have time for maybe one more question or so. There's one here at the very end. Let's see. Do you see this? Can you comment on inappropriate flow and I time settings? Okay, so for assist control, again, this is also one of the reasons of doing the quick CPAP trial, is that it allows you to see what the patient is trying to do. So normally, you and I have a resting peak flow rate of about 30 liters a minute at rest. And patients that are when at maximal exercise, humans peg out at a peak flow rate of about 180 liters a minute. Now, as soon as you stick an endotracheal tube down someone, that goes down. But
the flow rate, I said a standard of 60 to 75, start out around 60, titrate to 75, is a way to kind of jump ahead and try to get control of the patient. But again, using a CPAP trial, actually measuring what the patient can do is a good way to do it. And a lot of patients, if they have muscle weakness or really sick, they can't generate very, very high peak flow rates. So again, I think you need to measure what each patient is doing. In terms of eye time, critically ill patients, our normal eye time is like 1 to 1.5 seconds. Critically ill patients generally don't need that fast of an eye time, that long of an eye time. So again, keeping it under 1 second, around the 0.7, 0.8, maybe even 0.9, is probably a good place to start and think about, and will help take care of some of these problems before they start.
Rich, I'm going to have to want to thank you for an excellent presentation. There are some kudos over in the chat box from our participants, but at this time we're going to have to wrap things up. And for those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.